Part 7, Chapter 37, we're going over acute kidney injury and chronic kidney disease. Acute kidney injury is a sudden cessation of the kidney function that occurs when the blood flow to the kidneys is significantly compromised. Manifestations occur abruptly. Different phases of acute kidney injury. Onset begins with the onset of the event of the injury, ends with the oliguria develops, and it lasts for hours and days. Oliguria begins with the kidney insult. Urine output is 100 to 400 mLs within 24 hours, with or without diuretics, and it lasts for 1 to 3 weeks. And the diuresis phase, it begins when the kidney starts to recover. Diuresis of a large amount of fluids, probably about 1,000 mLs to 2,000 mLs per day, and it can last for 2 to 6 weeks. Death can result from dehydration and imbalance of serum sodium and potassium levels. And then we have the recovery phase. It continues until the kidney function is fully restored, and it can take up to 12 months. And on this slide, you will see different types of acute kidney injury. The pre-renal, it occurs as a result of volume depletion and prolonged reduction of the blood flow to the kidneys, which leads to ischemia of the nephrons. It occurs before damage to the kidney. Early intervention restoring fluid volume deficit can reduce the acute kidney injury and prevent chronic kidney injury disease. Intrarenal, it occurs as a result of direct damage to the kidney from lack of oxygen, indicating damage to the glomeruli, nephrons, and tubules. And postrenal occurs as a result of bilateral obstruction of structures leaving the kidney. Acute kidney failure can occur when you have a condition that slows blood flow to your kidneys, experience direct damage to your kidneys, or urine drainage tubes, ureters, become blocked and waste can't leave your body through your urine. The impaired blood flow to kidneys, diseases and conditions that may slow the blood flow to the kidneys and lead to kidney injury include fluid or blood loss, blood pressure medications, heart disease, severe dehydration, liver failure or infection. Damage to the kidneys, diseases and conditions and agents that may damage the kidneys lead to acute kidney failure. Could be blood clots, cholesterol deposits that block flow in the kidneys, glomerular nephritis, which is the inflammation of the tiny filters in the kidneys, the glomeruli. Usually infection, such as a virus that causes coronavirus disease, that can actually cause that. Toxins such as alcohol, heavy metals, cocaine, and also medications of certain chemotherapy drugs, antibiotics, and dyes that are used during imaging tests are amongst the many causes of acute kidney injury. Prevention for acute kidney injury is to check glomerular filtration rate and serum creatinine prior to the contrast media or nephrotoxic medications. Follow protocols to prevent contrast-induced nephropathy. Hydrate before and after contrast media, and monitor peak and trough levels for nephrotoxic drugs per institute policy. Common nephrotoxins that cause acute kidney injuries are antibiotics. Certain antibiotics such as aminoglycosides, which gentamicin falls under that category, cephalosporins, sulfamides, or tetracyclines. Analgesics such as acetaminophen, non-steroid anti-inflammatory drugs. Other drugs include ACE inhibitors, heavy metals such as gold, lead, lithium, and contrast media, which is used for diagnostic testing such as intravenous pyelograms or cardiac catheterizations. And also chemicals such as like gasoline, kerosene, or turpentine. They all cause acute kidney injury. In addition, here's more common nephrotoxins. Here's a list of them. With any nephrotoxin medications, check the GFR, any kidney function like the BUN, creatinine. Those are important because these drugs are excreted or metabolized significantly through the renal system, through the kidneys. There are other drugs such as the ACE inhibitors, heroin, heavy metals such as gold and lithium, like I just mentioned earlier. And here are the contrast media, organic solvents. They all cause acute kidney injury. So in acute kidney injury, it has three phases. After the initiating phase, which is the onset phase of the event occurs that caused the acute kidney injury. In the oliguric phase, it is the patient has less than 400 ml of output in 24 hours. It occurs in 24 hours to 7 days from the initial phase. It can last 2 weeks or several months, it depends. There is a fluid retention, which is fluid overload, and there is electrolyte imbalance, which with potassium increases. And while that happens, the sodium is lost in the urine, and that can result into hyponatremia. It also has neurological effects in this phase, ranging from confusion to seizures and ultimately coma. And it also has buildup, and as it progresses, it can build up waste, so it's not excreted. And the next phase, in the diuretic phase, which is phase 2, as the kidneys begin to excrete waste products, 1 to 3 liters a day of urine is produced, in which osmotic diuresis occurs from the elevated waste products, urea, which the body is attempting to eliminate. The kidneys are not yet able to concentrate urine, so the dehydration and hypotension are a concern. It is important to monitor for hypovolemia, hyponatremia, hypokalemia, and hypotension in this phase. Serum BUN and serum creatinine levels are high until the end of this phase. And this phase can last up to 1 to 3 weeks. And the last phase, the recovery phase. In this final phase, recovery begins in the GFR as the GFR rises. Serum waste product levels, BUN creatinine, decrease greatly within the 2 weeks of this phase, and this phase can last up to a year. And those who recover usually do so without complications. However, older adults are more risk for reduced recovery. Renal function, and those who do not recover in renal function result in the chronic kidney disease occurs. Continuous renal replacement therapy is one of the renal replacement methods that include intermittent hemodialysis or peritoneal dialysis. It is intended to be applied for 24 hours or longer through continuous slower dialysis. Continuous renal replacement therapy acts as a renal support through blood purification to allow solute and fluid homeostasis. So during the continuous renal replacement therapy, a permeable hemofilter is attached to the vascular access, and blood flows through the hemofilter, and excess fluids and solutes move into the collection bag. The remaining of blood returns to the patient via venous access, and if desired, replacement of fluid and electrolytes can be given through the vascular access. You want to monitor INOs, fluid and electrolytes, daily weights, and hourly vital signs when this procedure happens. And vascular access is essential. Chronic kidney disease involves a gradual loss of kidney function. So your kidneys filter waste and excess fluids from your blood, which are then removed in your urine. Advanced chronic kidney disease can cause dangerous levels of fluid, electrolytes, and waste to build up in your body. And in early stage of chronic kidney disease, you might have a few signs or symptoms. You might not even realize that you have kidney disease until the condition is advanced. Treatment for kidney disease focuses on slowing the progression of kidney damage, usually by controlling the cause, but even controlling the cause might not help the kidney damage from progressing. Chronic kidney disease can progress to end-stage kidney failure, which is fatal without artificial filtering via dialysis or kidney transplant. The causes of chronic kidney disease are numerous. The most common include diabetes, resulting in diabetes nephropathy, chronic high blood pressure causing nephrosclerosis, glomerulonephritis, and autoimmune diseases. So when a patient has chronic kidney disease, at this point, a large portion of the nephrons are damaged, and it is progressive within 5 stages. Usually, early stage is about 75% nephrons lost, which is renal insufficiency. And end stage kidney failure is 90% nephrons are lost. Uremia, you get an increase in the blood and is present in chronic kidney disease. Patients eventually develop problems in all systems. And if left untreated, the patients with uremia dies within a short time. In most cases, findings of chronic kidney disease are related to fluid volume overload and include the following of in neurological, is you're going to see lethargy, decreased attention span. Cardiovascular, you're going to see a jugular distension, hyperlipidemia, heart failure, orthostatic hypertension. You're also going to see a peak T wave on the EKG, hyperkalemia. Respiratory, you're going to hear crackles in the lungs. And hematological, you're gonna have pallor, weakness, dizziness, anemia symptoms. And gastrointestinal, you're gonna have ulcers in the mouth, throat, foul breath, and blood and stools and vomiting. So patients with renal disease, they can have a complex dietary requirement and need guidance of a dietitian who specializes in renal treatment. Dietary restrictions will vary, and this is based on the patient's renal disease type and treatment, and general guidelines that include the following. You want to restrict fluids. You want to have adequate caloric intake is needed to maintain the ideal body weight and protein stores. Simple carbohydrates and monosaturated and polysaturated fats are given freely because their end products, carbon dioxide and water, are less likely to tax the kidneys than protein. Potassium is restricted for patients with oliguria, and salt substitutes are often potassium compounds that patients need to be educated to avoid. So definitely have them avoid salt substitutes because they do have the potassium compounds. Sodium is restricted based on the elevated pressure, degree of edema, and laboratory findings. So medications early in the disease, diuretics are given to increase output, and ACE inhibitors, ARBs, calcium channel blockers, or beta blockers may be used to control hypertension. Phosphate binders are given with meals to reduce phosphate levels. Calcium and vitamin D supplements are used to raise calcium levels. Both the active and storage forms of vitamin D should be considered to decrease fractures, cancer, and infection rates to improve cardiac function. Agents to lower potassium levels are also used if needed. And all drug therapy is closely monitored because the kidneys are unable to effectively remove the medications from the body. And as renal function decreases, the patient who requires insulin, they may need smaller doses of some long-acting insulins. Dialysis is a treatment for people whose kidneys are failing. So when you have kidney failure, your kidneys don't filter blood the way they should. As a result, wastes and toxins build up in your bloodstream. Dialysis does the work of your kidneys by removing waste products and excess fluids from the blood. So dialysis started when a patient develops symptoms of severe fluid overload, high potassium levels, acidosis, pericarditis, lethargy, fatigue, or symptoms of uremia that are life-threatening. Both peritoneal dialysis and hemodialysis involve movement of the diffusion particles from the area of high concentration to the area of low concentration through a semi-permeable membrane. Substances move from blood through the semi-permeable membrane into the dialysate, and fluid and electrolyte imbalances can be corrected with the dialysis. Dialysis also can be used to treat drug overdoses as well. Moving on, here are the foods that contain are high in potassium. Is this where you're going to educate your patient on such foods? It is important, especially on people who are on dialysis. And that is it for this content for this video.